So it's going on so interesting that nobody wants to have tea, it seems. So with this, we move on to our next keynote address session, and that's the very important session of the whole conference. We can call it as a heart of the conference, and that would be about the psycho-neuro-immuno-endocrine correlation. So this is something which is very, very important, and what we are looking at is um, hearing from Padma Shri Professor Dr. Shashank Joshi sir, Dr. A.K. Das sir, Dr. Manoj Chadda sir. So all the eminent personalities of India. So for this, I call upon the moderators, Dr. Preeti Patale and Dr. Mukun Panukar. Please come on the dais, ma'am and sir. Dr. Preeti Patale. She is a childhood obesity specialist, and she is a pioneer of childhood obesity subspecialty, exclusively practicing childhood obesity. She is a national fellow of the SCOPE program, um, which is a very important program which has been held in India. She is a part of task force member and to fight against the non-communicable diseases like obesity, diabetes, and cancer. She's a vice president of IRO Maharashtra chapter. She is author of many specialized obesity clinics and many books which have been written for childhood obesity. She has many publications and she has many publications on her name, and she has published many scientific papers in many prestigious conferences of RSSDI, ADA, IDF, and so on. So with this, uh, and about the other moderator, Dr. Mukun Panukar. Dr. Mukun Panukar, he is a consultant physician, diabetologist, and intensivist, prominent figure from the city of Pune. He has worked relentlessly at the forefront during COVID pandemic and was felicitated by Health Minister Mr. Rajesh Tope and respected Devendra Fadnavis. He is he's the founder of the hospital called Shashwat Hospital, and he is the director of Sanjeevan Hospital currently. So he's been attached to various hospitals in the city as well. And most important, he is the secretary of API Pune chapter. So with this introduction, I hand over the session to you, both moderators.
Thank you. Thank you very much, Sonali, for the kind introduction. We will go on to this session by Padma Shri Professor Dr. Shashank Joshi. I think Dr. Shashank Joshi doesn't need any introduction to any audience in India, but some notable things we would like to tell about him. He is at the Nilavati Hospital and Research Center, Department of Diabetology and Endocrinology, president of two important organizations, the Indian Academy of Diabetes and Endocrine Society of India, former president of API and RSSDI, and is involved in the activities of American Association of Clinical Research, Clinical Endocrinology, AAC, and is serving as the chairperson of its India chapter. Recipient of International Clinical Award received at the 21st American Association of Clinical Endocrinologists Annual Scientific and Clinical Progress, Philadelphia. Senior editor of Endocrine Connection, a journal of European Society of Endocrinology, and delivered more than 200 orations nationally and internationally. I think there is hardly any association in medicine field wherein he is not involved or he was not at the helm of that particular association. And that's a very big achievement. And we have seen him during the COVID almost every day on television. So he is going to speak to us on happiness, the neuroimmunoendocrine correlates. Over to you, Shashank Joshi, sir.
Am I audible and are my slides visible?
Yes, sir, you are audible.
And my slides are visible?
Right, sir.
Okay, thank you so much for the kind words of introduction. Let me at the onset thank Dr. Vaishalideshmukh and the entire team of Synapse 2022 for keeping happiness as a part of this whole exercise. And my job has been made very simple by Professor Gangadhar when he said, Prasanna Atmam, because human beings on planet Earth have two types of Atmas. One is Prasanna Atma and Trupta Atma, and second is Atrupta Atma, or a disgruntled soul. What I'm going to talk in the next 20 minutes, and I know tea is served, so maybe there is no audience. And I also know that, it's a pre-lunch time, so people get hypoglycemic and they don't tend to be happy. As well as I also know that we are running a little late because we have something called Indian stretchable time. Having said that, I want to go through a journey which Vaishali asked me to do of connecting the dots between psychoneuroendocrinology, the untold story. And I'm basically going to talk in the next 18 to 20 minutes on the biological correlates of neuroimmune and endocrine connections. So we know that we burn brightly without burning out, is what Richard Briggs said. And that's really the whole connection between psychoneuroendocrinology. And fundamentally, this is a clinical study of hormonal fluctuations or endocrine fluctuations and their relationship with human behavior. It has a psychiatric correlate, it has a psychological correlate, it has an endocrine correlate. And obviously, from a psychiatric perspective, they looked at mood disorders and they look at neuroendocrine changes affecting the brain. And a very elegant, correlate of depression model with yoga was described by our previous speaker. And from an endocrine perspective, we look at endocrine disorders, which are associated with negative health outcomes and psychiatric illnesses as well. So obviously, when there is a brain dysfunction associated with the HPA axis, which is the hypothalamo-pituitary adrenal axis, which affects the endocrine system, that really results in a trigger point for physiological and psychological symptoms. And therefore, it is a very, very complex blend of psychiatry, psychology, neurology, biochemistry, and endocrinology. And this we need to understand and comprehensively connect the dots and look at symptoms related to brain, related to the endocrine system, and to psychological health. So what is this psychobiological concept? And this concept in the modern world is called as PNEI, the psychoneuroendocrine and immunological concept. It's a scientific field of study that looks at the link of bidirectional communications between nervous systems and endocrine systems and immune systems, and their crosstalk with physical health. It's basically a paradigm shift from a biomedical health and disease, hermetically sealed compartments, into a more integrated and interdisciplinary approach. So obviously, it's all the crosstalk between the psychoneuroendocrine and immune systems. And one of these is of course used in an evidence-based way in dermatology, where they are looking at low dose medicines through research for treatments for rebalancing immune balance disorders. We have seen this in PMS and premenstrual dysphoric disorders. Very clear correlates now established on the biological correlates and the endocrine correlates on the PMS syndrome, which is nothing but a late luteal phase disorder. And we all know that that gets magnified and correlated. We also have very good correlates of the postpartum depression models. And we clearly know the postpartum blues, which are so evidence-based and very well studied. We have also moved on from there to, the postpartum depression as a model and postpartum psychosis as a model. And obviously, we look at, cortisol stress responses. So fundamentally, it is the stress-induced release of cortisol, which is detrimental to health outcomes. It is that so-called sympathetic response, the cortisol stress response, which fundamentally, is very, very essential for the, stress response in healthy adults. And from health to unhealth is the symphony which is broken. So fundamentally, the neuroendocrine immune symphony has inflammation as a central theme. And the inflammatory response provides a powerful means of the body to fight infection. And that's what we saw during the COVID times, that the neuroendocrine system plays a very, very important role in controlling the magnitude and duration of response to maintain the milieu interior of homeostasis, particularly in inflamed states. And we know that the corticosteroids, particularly glucocorticoids, are released following activation of hypothalamo-pituitary adrenal axis. And that limit really the synthesis of pro-inflammatory molecules, while physical hormones or non-neurophysical hormones like vasopressin and oxytocin, which are the love hormones, both within the brain and periphery, maintain the cardiovascular and metabolic homeostasis. So if you see, the only drug which was evidence-based in the COVID era with cytokine storm was glucocorticoids. And that's clearly an example of the neuroendocrine correlate of an inflammatory response which was exaggerated. Most people due to COVID did not die due to COVID. They died either because of a cytokine storm, and most of the cytokine storm, if treated appropriately on time, was reversed by glucocorticoids. Carl Sandburg said, nothing happens but a dream, and first to dream. So, this is a very nice article I would all urge you to read from Aditi Nerurkar, who works in the integrative medicine department at the Harvard Medical School, and it's on happiness. And she talks about what a happy cell looks like. It's fundamentally a mind and immune system which are intrinsically linked, and our body is a product of that environment of the mind and the immune system. So we know that, fundamentally, there is a new field of mind-body genomics, which looks at how life satisfaction, how we are satisfied, looks at cellular functioning and DNA. So Professor Stephen Cole, who actually does work at UCLA, he defined what is the truest form of happiness. And it's actually science, because science is measurable, science is finite. And in the current evidence-based era, we want to make everything very measurable. So his lab really investigates the connections between two shelves, emotional shelf and the biological shelves of happiness. So the old school bodies think that our human body is a very stable biological entity, separated from the external world. But the modern molecular cellular biology tells us that our bodies are very fluid and permeable. And you saw some excellent MRIs from Professor Gangadhar's talk, how our body changes to adaptation of emotions. So remember, happiness is directly linked to functions of immune cells. And we know that our immune cells have two programs, one which fight the virus, one which fight the bacteria and inflammation. Those are the two programs they are intrinsically programmed for. And Professor Cole's work, Steve Cole's work from UCLA, has shown that when there are negative experiences, like when somebody gets cancer, somebody is depressed, somebody has post-traumatic stress disorder, or somebody is from low socioeconomic status, it is linked to an increased activity of inflammation genes in the immune cells. That's what his work has shown. Clearly, this concept of immune cells registering the concept of happiness is a concept where philosophy connects with cell biology. And that's very difficult to understand at times, because, many a times when you talk of happiness, people think of philosophy. And then, people think of quasi science, which is why I really admire Dr. Vaishali taking this initiative and persistently continuing this initiative of connecting science and cell biology with philosophy. So, in philosophy, there are two types of happiness. One is the hedonic well-being, and second is the eudaimonic well-being. And Professor Cole's lab investigated evidence based on both these correlates. And we know that, our balance of immune system is based on life experiences. So when we have a lot of positive emotions, there is something called as hedonic well-being. But if you want really better gene activity on your immune profile cells, then you should have an eudynamic well-being. So remember that happier you are, more satisfied you are, less is the inflammation, better is the immune response, better are the antibodies. So this is something very, very clear, that positivity breeds happiness, and happiness breeds better immunological, anti-inflammatory responses, and so on and so forth. Also remember that meditation has a huge impact, and this is what we have learned from our ancestral medicine. And now there is a whole new science of mind-body genomics. We know that meditation can enhance telomeres and DNA and alter aging as well. The main thing which we need to know in this psycho, neuroendocrine and immune correlate is stress and science. Because that in human biology, stress and disease is a very popular term. but it's also a very ambiguous term from a medical context, because there is a lot of subjectivity in experience of stress, and the physiological stress mediators are not well defined. We know the GAS, where there is an alarm stage where stressor disrupts body stability, temporarily lowering resistance. Then we have a resistance stage, which is an adaptation stage to combat stressors at a higher level. And then we have an exhaustion stage where the body runs out of adaptation energy stores for adjusting to the stressors. And obviously, then there is a recovery stage. So this is a typical GAS, which we all know. Common stresses are many, including personal life stresses, but one of them is job stress. You know that, just take India, for example. 50% of employees suffer from stress-related problems in India. Indian employers rank stress as the #1 lifestyle risk factors. 80% of job accidents are stress-related, and absenteeism due to stress has increased by around 300% in the last 20 years. Coping with stress has a lot of physiological and endocrine responses. We all know the more blood flows into the brain and their senses sharpen, pupils dilate, there is a visual perception, hearing ability increases, perspiration and salivation decreases, perspiration increases, respiratory rate and heart rate and blood pressure go up, the digestive system slows down, and the blood supply is diverted to critical areas. The liver and fat tissues release, glucose more in the stream. The ability to clot more increases, and the immune activity decreases, and there is more blood to flow to the muscles, and the urine production increases. But if you look at the short-term adaptation and long-term maladaptation, that is the key thematic in the psychoneuroimmune apparatus. So if you look at corticosteroids, for example, in the acute adaptation, it's basically to provide glucose fuel, increase food-seeking behavior, while in the chronic outcome of the hypercortisolytic state is hyperglycemia and fat accumulation. If you look at epinephrine or adrenaline, it increases pulse rate and sympathetic response and blood pressure, but in the chronic state of sympathetic state leads to hypertension and arrhythmias. And if you look at the brain, the amygdala and hippocampus, when we combine it with the autonomic nervous system, it's alertness, fight and flight response, and chronic states, it's all death of neurons, atrophy, and aging. So obviously, when you look at the biochemical changes of chronic stress and genetic damage, you can clearly see that there is a role for corticosteroids and epinephrine, insulin resistance and cytokines, down regulation of testosterone, the DNA damage and DNA repair with oxidative stress. But the true way to measure stress is something called as allostasis and allostatic overload. So in human biology now, whenever we look at the measurement of stress, that is typically done by a normal allostatic response, in which a response is initiated by a stressor and sustained for an appropriate interval and then turned off. For example, multiple periods of poverty, level of income, non-habituation on public speaking. And then, of course, there is an allostatic load. So prolonged increase in cortisol due to sleep deprivation, which is so common. And short stress response is more cytokines, more autoimmunity. So there are different responses, based on environmental stressors, whether at work, home, or neighborhood, major life events, trauma and abuse, behavioral responses, and all of them determine the allostatic load. So that's the true way to measure stress. And then fundamentally, the allostatic load decides whether you are adapted well or not adapted well. And if you are not adapted well, then obviously this is what happens. And some of that correlate was shown by Dr. Gangadhar. The prefrontal cortex will atrophy, the hippocampus will atrophy, and the amygdala will hypertrophy and later on atrophy. That's how it goes. And obviously, how do we measure allostatic load? Well, of course, systolic and diastolic blood pressure, indices of cardiovascular activity, waist-hip ratio, lipid profile, DHEAS, overnight urinary cortisol secretion as an integrative measure of 24 and 12-hour HP activity, and of course, overnight, epinephrine and norepinephrine levels, and integrated indices of 12-hour sympathetic nervous system activity. Of course, many of these correlates are used for research purposes. And ultimately, we know when there is chronic stress and allostatic overload, you can get diseases from all areas, whether it's coronary artery disease, gastrointestinal diseases, skin or asthmatic diseases, or even psychiatric illnesses. And we also know that there is a direct correlation, whether it is job stress, marital stress, low socioeconomic stress, with hypertension, cardiovascular disease, and mortality. And there is a very good statistical odd ratio for the same. And we all know that it leads to a dysmetabolic state, when there is a chronic stress, the HP axis and the central response is evoked. The sympathetic nervous system response evoke altered behaviors, and reactivity to stressors will lead to a myriad of metabolic syndromes and cardiometabolic diseases, which I don't have to allude. And obviously, all this chronic stress produces a lot of steroids, and they falter and make us immunocompetent. In fact, there are more than 293 independent studies, and a meta-analysis confirms that stress alters immunity. So that evidence base is very, very compelling. And the elderly and the sick are more prone to stress-induced immunity. And it's all linked then to addictive behavior, and it's all linked to obesity, and it's all linked to weight gain, which was alluded by our previous speakers. It's also linked to shortening of telomere activity. And we can clearly see that data worldwide, that all cause and or cause specific mortality has direct correlates with allostatic loads from different countries. So it's all ultimately about stress management. Actually, the most classical example when you talk in stress management is a diamond. Diamond is nothing but a piece of charcoal that's handled stress exceptionally well. And clearly, the best form of a stress buster is happiness. And exercise is a relaxation technique for that. I don't want to go into details. We have adaptogens, because when we want to enter a stress-free zone, you need to be happy. The reason I'm looking at that is there is something called as adaptogens. Adaptogens, the term coined by Nikola Lazarev in the 40s, and he looked at medicinal plants which augment stress, concentration is improved, performance is improved, and attention span is improved, and fundamentally reduce the stress-induced impairments on neuroendocrine and immune systems. And these adaptogens are all seen in our day-to-day life, and we can see that they all come through the plant medicine. So obviously, adaptogens basically regulate homeostasis. They mediate and have a very good correlate to counter stress responses, and they have a neuroprotective, anti-fatigue, antidepressive, anxiolytic effect. So obviously these adaptogens have been seen, they are not stimulants really, like a simple green tea or a ginseng or a garlic or a carotenoid or a vitamins or a micronutrient. And then also it could be Om chanting. You saw very clearly, Dr. Gangadhar telling us that we have a simple chanting like Gayatri Mantra, for example. And we know that before creating the four Vedas, Brahma created Gayatri Mantra with 24 letters. Every letter of this mantra is instinct. It is refined with some energy from the four Vedas with branches and sub-branches like a banyan tree. And obviously it has sprouts and it has innumerable twigs and branches, it leaves and flowers and fruits. So when we look at the science of Chetana and Prarabdha, and when we look at the activity of the Chaitanya creation, it's all the ego, the determination, the inspiration, and then the Jad creation in the form, the color, the shape, and it is all dissolved in the vibrating energy. You can clearly see the atomic principles behind the creation of Jad, the creation of Chaitanya and the conscious will. And clearly when they have to be balanced, the Chaitana is consciousness, Prarabdha is matter, and obviously, you now have very clear data to show that Gayatri Mantra can be uttered with the word Om. And in fact, the photograph here is of Dr. Professor Shambho Samajdar from the Calcutta School of Tropical Medicine. In 2020, we did a study with him where we used Gayatri Mantra chanting for attention, memory, anxiety, and mental health states for young athletes. Because of the COVID, they were under stress. And just by doing simply, we need to do better modeling and research in some of our ancient Vedic techniques just to make them happy. So remember that this is something from Buddhist literature, and you know that Buddha had an eightfold path on the 8 spikes of the wheel for different patterns of life to make you happy. The right understanding, the right speech, the right livelihood, the right concentration, the right mindfulness, the right effort, the right action, and the right intent. And clearly it's all about happiness. So clearly, if you want to be happy and if you want to really live life well, you need to think positively. You need to make sound become music. You need to ensure that your movement becomes a dance. You need to ensure that your smile becomes a laughter. You need to ensure that your mind becomes meditation. And of course, you need to ensure that life becomes a celebration. So obviously, you need to throw your heart over the fence and the rest will follow. But remember that we need to slow down. We need to keep calm. We need to be positive. We need to take it easy. We need to unplug and enjoy life, have fun, breathe, relax, go outside. I'm sure most of you all are having and enjoying your tea, and of course, meditate. Thank you, Vaishali, so much for keeping happiness as a part of your theme of a meeting.
Thank you, Dr. Shashank, for very enlightening and insightful lecture as usual. And definitely the two messages which I want to emphasize is that happiness linked to the function of immune cells. This is the one which we all can emphasize. And another thing that you are giving the example of diamond for stress handling. We ladies are very fond of using the diamonds. Now we can wear the diamond of proper stress handling. Thank you so much for this enlightening talk. And thank you for Dr. Vaishali and her team for arranging this wonderful conference. Definitely, it will be of no doubt academic importance, but it will percolate its benefit to the society also. And I'm very happy to be a part of this esteemed conference. Thank you once again. The next speaker, just sorry.
You can take one question. Madam, please introduce yourself.
Hello, Dr. Shashank, can you hear me?
Yeah, you're audible.
I think we met about 10 to 15 years back when you had come as a guest to IMA Kota. And I was the secretary of IMA Kota. And we had a great function in the hospital where after 3 whiskeys, I told you I was a diabetic. And you said you were almost, suicidal. So for the last 10 years, Doctor, every evening I have enjoyed my drink. And last night I had my 63rd birthday party where I had downed, I think, 3 whiskeys or 4 whiskeys, vodka and, Bloody Mary and whatnot. And we danced the night away till 3 o'clock in the morning. And here I'm in the conference and I'm still alive. I'm not yet suicidal.
That's very good. That's very inspiring, and but that's not a good example to lead on. But as long as you're happy, it doesn't matter.
But I want to tell you, my question is that now from duloxetine and memantine, we are going to adaptogens and Om chanting meditation Gayatri Mantra. What is the message to the new MBBS students? Are these going to be inculcated in the MBBS course? Or are we, as old doctors and physicians practicing, indulging in all these kind of, paramedical sciences? Our new graduates are not going to be inducted into this Ayurvedic medicines. Like, are we going to prescribe Brahmi, Amla, and Hartaki instead of memantine and duloxetine? And if that is so, do we have to do the bridge course? Now we know about the happy cells, what the adaptogens are doing, and the Om mantra. But we should be able to legally prescribe these forms of treatment to our patients. Otherwise, these conferences have no use for us. What do you say about that?
So I think this is work in progress. It's a science of integrative medicines. It is for us from the allopathic side of medicine to generate evidence from our ancient systems of medicine and our scriptures. So it is, like you saw Dr. Gangadharan generating some evidence. You saw Professor Samajdar from Calcutta School of Tropical Medicine generating evidence. It is always better if you can chant Gayatri Mantra and reduce anxiety rather than pop a Rivotril and reduce anxiety. So I can tell you from personal experience that chanting mantra has definitely calmed me down, and I can say that for sure that I'm a much more calmer person than what I was before. So I think we need this is anecdotes, but anecdotes need to translate into research. Research needs to translate into evidence, and I'm certain that some of these ways of life, like yoga, pranayam, meditation, is a way of life. We are not here to advocate other alternative or complementary systems of medicine or allopathic systems of medicine, but we are here to learn a happier way of life. And we are here to generate evidence based on the knowledge and wisdom we have. Because, the point is, we have been imposed and thrusted upon a very British school of medicine, a very didactic school of medicine. And therefore, we need to move out of that anglicized mode into a more truly holistic Vasudevam Kutumbam mode and a holistic mode of a one world, one village approach. And we should be open to thinking, but we need to generate evidence. So we should not take quasi-science. I completely agree with you, ma'am. But we need to take everything put it through the rigor of evidence-based medicine and generate a level of evidence through an RCT so that we can prove the point that what our ancestors were thinking probably had some sense and rationale. And we also need to adapt it to the modern era. I completely agree with you there.
And if you can allow me to interrupt, the purpose of this conference is to convert this notion that mind-body medicine means yoga and meditation. The concept is that every person needs to have some form of a mind-body practice into their daily living. It may not be through a retreat, through meditation to becoming a yogic person, but it may be in the form of finding his own flow, in the form of reading maybe mind-body medicine to someone, exercising maybe mind-body medicine to someone. So we are here to talk science and not promote yoga or meditation or XYZ pathy into this. We are talking about taking care of your own mind health on day-to-day basis, wherever you are, in your clinics, in your classrooms, in your house. And it has nothing to do with any sort of retreats and any gurus and any spirituality. I think I'm very clear on that.
Yeah. Thank you, Vaishali ma'am.
Thank you, Vaishali. That we are here to talk science, but we need to be happy. So, ma'am, don't feel that we are here to thirst anything on anyone. You remember one thing, that we are all here to self-realize the value of being calmer and happier.
Thank you so much. The next talk will be by Professor Dr. Ike Das, Senior Endocrinologist from Pucheri, on topic mind health in diabetes management. Sir actually doesn't need any introduction, but as a formality, he's an PIMS former professor and head of endocrinology, JIPMER, Pondicherry. He's a former director for Indian Institute of Diabetes, Trivandrum. His overseas experience was King's College Hospital Diabetic Department, London, from 1985 to 1987, in the Department of Diabetes and Molecular Medicine from Karolinska Institute, Sweden, and visiting professor to Mayo Endocrine Diabetes Department, Mayo Clinic, Rochester. Sir, over to you.
My dear and esteemed chairpersons and the dear audience, I'll straight go to the subject because we will be in time. Dear friends, thanks to Vaishali and the team for giving me a topic which is very exciting. I'm going to speak today on a very most contemporary and challenging topic for this conference, mind health in diabetes. Dear friends, I'll go to the subject directly as I just described. What is the background? What is the fact sheet of mind health in diabetes mellitus? My dear audience and the students who are in the audience, I must tell you that a lot of effort has gone into preparing this lecture. So please be a little bit attentive while you relax also. Now, it's like this, that people living with type 1 or type 2 diabetes, at least 1/3 of the people are at increased risk for a terrible trial of this mind health in diabetes mellitus. Like, what are the terrible trial? They are depression, number 2, anxiety disorders, and number 3, eating disorders. The second fact, now about 1/3 of the people with diabetes and mental health receive a diagnosis and proper achievement and proper treatment, whereas 2/3 do not receive a proper diagnosis. It is most often forgotten, most often not come to the arena of the diagnosis for the treatment. So 2/3 of the cases of mind health diabetes we normally miss. Third, the biggest challenge to treatment, to provide treatment for the mental health conditions for people with diabetes. What is the greatest challenge? The greatest challenge, the low rates of detection. The detection of the mind health challenges in diabetes, my dear friends, are very low. Number 2, up to 50%, 45 to 50% of mental health conditions and cases of very severe psychological distress in the diabetics goes undetected. They are treated for diabetes. They are not treated for this diabetes distress or psychological distress. Therefore, the diabetes mellitus treatment team, as Vaishali had rightly done it here, need to be aware of the mind-body connections and ensure the whole integrated care that Shashank spoke about. Dear friend, what are the manifestations of diabetes regarding the mind health? To my mind, there are many, but I picked up 4. Number 1, cognitive impairment. Sanjay Kalra, one of our team leaders, gave the concept of euglycemic happiness, which was repeated here twice before. He also spoke about euglycemic euthymia. And these are the guiding principles of diabetes treatment, that if one has high blood glucose, there is no happiness, there may not be happiness, and that can produce cognitive impairment. Diabetes and the high blood glucose can be a factor for the mind health manifestation like Parkinson's, for the CVA, and also very, very common mental disorders, including depression. I've got you 6 elements of diabetes and cognitive dysfunction. Number 1, if the diabetes increases the risk of cognitive dysfunction. Number 2, long-term diabetes can be a risk factor for dementia by a factor of 2-fold increase. Number 2, diabetics can get accelerated cortical dystrophy, cortical atrophy. Diabetes and memory. Now, diabetic mellitus patients can have memory attrition more than the non-diabetics. In type 1 diabetes, the disease when diagnosed below 7 years of age are prone to more severe cognitive dysfunction. And if you do a DTI, diabetes diffusion tensor imaging, one can find that there are microstructural abnormalities in optic radiation, posterior corona, hippocampal region, white matter involvement, which Dr. Gangadhar also showed about, underlying the concept of mental slowing. So, dear friends, I brought for you these 6 cognitive dysfunctions which are paramount in diabetes. Now, I'll just take your attention to clinical studies, the most important, the Accord Mind study. Dear friends, there has been in the Accord Mind study evidences a statistically significant age-adjusted association between the A1C level and the cognitive score in the 4 areas. Number 1, in the DSST score. DSST score stands for the structural matching. Number 2, in the MMSE score, you know what it is about. A 0.11 point lower memory score and the OR score or the Stroop test. Therefore, a hyperglycemia in the Accord test showed that there is association between the hyperglycemia and the mental health. Dear friends, Alzheimer's disease has been termed as type 3 diabetes. Impaired insulin activity, I'll make it very simple. The impaired insulin action in Alzheimer's disease having dementia is a hallmark. In many animal research studies and the cognitive performance, it has been said that insulin deficiency can be a part of underlying mechanism of the Alzheimer's disease. And this does occur in type 2 diabetes mellitus. It has been also shown that Alzheimer's disease is associated with insulin resistance. So, my dear friends, I like to draw attention that Alzheimer's disease has a very strong correlation with diabetes mellitus. Dear friends, coming to the common mental disorders that happen in diabetes, I have brought into 4 classes. Number 1, from the Whitehall study, CMD stands for the common mental disorder. It was about 9 to 15%. Many of them are Indians. Depression, clinical depression was between 8 and 2%. And 44% patients were common mental disorders. They had recurrent mental disorders, like 47% became with recurrent depression and 85% with recurrent clinical depression cases admitted to hospital. Therefore, that is the state of the nation regarding the common diabetes and the common mental disorders. Now, what is the risk of developing these common mental disorders? In a prospective analysis, it has been shown men who take higher sugar from sweet food or beverages had 23% increased odds ratio after 5 years of developing some sort of a mental disorder. Therefore, it has been said that sugar is a type of white poison. If you look at the prevalence of depression and diabetes mellitus, it is higher in the 28% in the women with diabetes compared to 10%, 18% with the males with diabetes. Shashank also showed this slide. And it is uncontrolled diabetes, it is much higher, 30% than 20% in the controlled diabetes. Mood disorders, anxiety has been reported in as far as 40% of case type 2 diabetes mellitus and more common in women than the men. This has been shown by Shashank. I'll not details of it. Suffices to mention that that this shows that in the diabetes related common mood disorders, common depressive disorders, there is a gender disparity. The women more prone than the male. Dear friends, it's cutting a long story, very long story, very short, that the degree of hypo or degree of hyper, both are bad. And other risk factors, which will come in a minute, and how long they're exposed to this type of hypo or hyper, other risk factors can impact the brain. Is shown here, typical diabetes, hyper exposure is a non-diabetic, which is flat, is a profound exposure to diabetic. You see how it is potentially rises. Same thing also is shown here, that if in type 1 diabetes mellitus, they can have hyperglycemia in children, but they may not manifest, may not come into the forefront. Children they are, but in the elderly, you find that this type of behavioral disorders do manifest. Dear friends, I have just brought for you from the literature a saying from a patient about his mind in a diabetes mellitus. Quote, I was misdiagnosed at age 55 as type 2 diabetic. I experienced severe highs and lows for 2 years, ranging from 32 blood sugar to 600 blood glucose. I felt a permanent change in my brain functioning, a change in the brain functioning from this experience. Once I was put on 24-hour insulin, there was improvement. So there is a lot of denial. Even though she was diagnosed at the age of 55, didn't accept she's diabetic, and the insulin altered it. But I can still feel the damage has occurred, and so she advocates that there should be screening, and a doctor can speak to all the patients about the possibility of long-term brain affection because of the high blood glucose. Now, if you look at the psychological needs, the mental disorder needs of a diabetic is a pyramid. Level 1, there is some difficulty in coping with diabetes. Level 2, greater difficulty in coping than level 1. There is significant but uncomplicated anxiety and depression. In the level 3, psychological problem like anxiety, depression, diabetes distress, phobias, this has all been discussed here. Now, in level 4, the significant difficulty in coping and self-caring in the context of multiple complexities, like something comorbidities, like complex trauma, substance abuse, social difficulties, plus depression, anxiety, diabetes distress. And last one is severe mental illness, dementia, eating disorder, in acute mental health crisis that can occur. And all this can become multiplied because of the comorbidities like hypertension and various diabetic musculoskeletal complications. Now, how do you model relationship between the behavior change and type 1 diabetes? It is the H1C rise or severe hypo, which can give rise to brain structure and function defect, micro and macroangiopathy, giving rise to diminished cognition, increased depression. And if you look at the type 2 diabetes mellitus, it is again similar. You add obesity, insulin resistance, and inflammation, and they all play a role in producing the behavioral change and brain structure function change, giving rise to diminished cognitive function and increased depression. Dear friends, it has been also said in the literature, it has to be investigated by Shali, that sadness and a long period of sorrow. I'm referring to a very profound statement in the scripture, a sadness or a long sorrow. I think Dr. Sarita Madam is going to speak about the thyroid and the emotion. Sadness and long sorrow and other depressive disorders can cause diabetes. It has to be investigated further. Dear friends, I have got few slides on the depression. I'll cut down for the purpose of time. Now, I'll just give us an example. Now, how does it impact self-care? If you say somebody you are a diabetic, or you say somebody you are a person with diabetes mellitus. So this goes to show the way we deal with our persons with diabetes that can make a lot of benefit, lot of change in their psychosocial, mental mood and approach. Similarly, it has been said that the point prevalence of depression by lost, it was found by lost men, what about 15-20%, lifetime risk about 33%. And the meta-analysis showed of 42 studies that presence of diabetes doubles the risk of comorbid depression. Now, the experience of diabetes can lead to distress, diabetic anxiety, and diabetic depression. And this can occur through the burden of the condition. It can impair the function and quality of life. Mood problems also may lead to poorer outcome. Dear friends, it's also said that if you compare the rates of depression with diabetes, very simple. If it is healthy control, 11%, about 27% in the diabetic. And therefore, it has been rightly said, I want to bring the statement here. It has been rightly said that, rightly said that depression with diabetes significantly associated with greater reduction in the health status. That is very important in a diabetic. All these things shows that with depression and without depression, you see the ambulatory visits, emergency visits, hospital inpatient stays, and the prescription medication file, all is more in the diabetics with depression. The other one also shows that the healthcare expenditure is always highest with the diabetic with depression. So that's a very important thing. And if you look to the outcomes in the depressed person with diabetes mellitus, there's a diminished self-care, diminished adherence to treatment, to exercise, medication, smoking cessation, whatever you say, eating a healthy diet. It contributes to increase the BMI, increase A1C, increase comorbidity, increase microvascular complication, and increase macrovascular complication. Now, it has been said that depression is frequently underdiagnosed, and patients are not willing to accept the psychological component, even in the motivational interviewing. So this is a very difficult situation we have to handle. Why does it go undetected? It goes undetected because people with diabetes and we SCPs, we quote unquote normalize depression in people with long-term condition like diabetes. We say, okay, diabetes, there's so many years, so depression is normal, natural, which should not be done. Therefore, and also in our country, a level of the psychiatric illness like depression, mood disorder is also as a undeserved stigma and may be registered. Now, if you look at the association between the depressive symptoms and the duration of diabetes, this is from the famous CESD study, that is the Center for Epidemiological Studies Depression Scale Study. You will find that as the duration of diabetes increases, the score increases. So it becomes very important to have it. The various risk factors that can further contribute and produce disorders they can be major depression, which can be the diabetic. It can be bipolar disorder, anxiety disorder, eating disorder, which we'll discuss in different forum. Now, there are various ways of diagnosing it with a 5x9 symptom per every day for 2 weeks. I don't details of it. I leave the slides with Vaishali or in the YouTube, or the associated symptoms I have listed here. It's very important to see emotivation, alexithymia, alexithymia, irritability, altered eating, poor self-care, medical symptoms reporting, isolation, helplessness, hopelessness. These are the pointers towards a depressive and mood disorder. There are many physical symptoms also that can be there, like polydipsia, polyuria, hunger, fatigue. I brought a scale for you, which shows that polyuria, polydipsia, hunger, sickness, somnolence, pins and needle sensation like neuropathy feeling, fainting, blurred vision, and what is the relation with the depression or relation of the HbA1c. Suffices to mention, the higher the HbA1c, the greater the symptoms, physical symptoms with depression. Dear friends, this is a cycle which shows that one has to be very careful about any mood change or depressive symptoms in a diabetic. And also I have brought an optimal health wheel from the literature that must be preserved in every diabetic individual. Number one, it centers around intellectual well-being, physical well-being, emotional well-being, occupational well-being, social well-being, and also the spiritual and the values well-being. So dear friends, we are here to discuss today not only about diabetes, the entire endocrine disorder, entire human health, and this optimal health concept, which at least has 6 components: spiritual, intellectual, physical, emotional, occupational, and social. And this can be done today by other things in association with MBA, mind body medicine. Dear friends, I will not details of it, but I want to give you that what are the risk factors for developing this depression and mood disorder in individuals with diabetes. Female sex, I told you. Adolescents, young adults, older adults. Poverty, we have plenty in our country. Few social supports, few in our country, multiple in our country. Stressful life events, poor glycemic control, especially recurrent hypoglycemia can push one into depression, mood disorders. Higher illness burden, longer duration of diabetes, and presence of long-term complications. And I must tell you that these psychological factors and reactions have negative outcomes in patients with diabetes. Please let us all remember, we cannot poo-poo this psychological mood disorders, the mind health medicine and diabetes, because they all have a negative impact on the outcomes of diabetes mellitus. I've given the outcomes. Now, how they produce the emotional crisis can give rise to shock, denial, anger, guilt, and anxiety. How diabetes can give rise to overwhelming. They say diabetes overwhelming us. We are very much anxious about diabetes. There is phobic reactions. It can give to psychiatric reactions. I have not time to describe in detail, but one day I'll come back to discuss in detail, because this is one of my passion, that how this psychological factors and reactions can drive negative outcomes in patients with diabetes mellitus in all sphere. So there can be poor glycemic control, poor self-care, and increased diabetes complications. We do not take care of it. Last 2 aspects of my talk is about the cognitive dysfunction. You see, the cerebral glycemia can give rise to cognitive dysfunction and depressive symptoms like memory function can come down, attention, executive function can come down, psychomotor mental efficiency comes down, and in the Hamilton Depressive Rating Scale, it goes higher. What is diabetes distress we talked about? Now, diabetes distress is the emotional burden of living with and managing diabetes. Emotional burden of living with and managing diabetes, unique, often hidden emotional burden, and worries a patient's it makes him overwhelmed to manage a chronic disease like diabetes mellitus. The need of the patient during diabetes distress is to be assessed and managed by self, by family and friends, and the care providers. Now, how do we screen for the mental health symptoms? The last but one part of my talk, one has to look for the PAID scale, the problem areas in diabetes scale. There is a PAID scale and diabetes distress scale. One can also look for the very simple WHO 3 or 5 screening instrument of QL, quality of life. We can look for the depressive and anxiety symptoms in the hospital anxiety depressive scale, HAD scale, PHQ-9, all of you know, CSD, all of us know, and big depression inventory. These are rarely required. I'm just giving it to complete my talk. But what is most important to remember that we have got wonderful tools today to indicate, I don't say diagnose, indicate there is something wrong in the mind health medicine and diabetes, like depression, general anxiety, cognitive impairment, quality of life impairment, and there are scales available. And if you want to do any study, like Gangadharan showed beautiful studies. I really, my day is made by his talk today. You know, there are scales which you can do to see an intervention. Vaishali is going to do research on this. To any intervention, how does it make this course improve and happen? Now, cognitive dysfunction, I've described at details of it, but it must also said that cognitive dysfunction is also associated with poorer diabetes control and poorer outcome. So cognitive dysfunction must be taken care for, and one can screen for the cognitive dysfunction by the MMSE, mini mental state examination, and there are many online tools available. Now, how all these occur? There is a link between the hyperglycemia. Now, there is a hyperglycemia-induced cognitive dysfunction like microvascular disease, hypothalamo-pituitary axis disease, advanced age products, polyal pathway, neurotransmitters, glial and hippocampal atrophy, and increased amyloid deposition. All this is known to us. We didn't know that this all produce cognitive dysfunction. It may increase the quantum of error in self-care. Be careful about it. Chronic cognitive dysfunction diabetes often affects the executive functioning like memory and attention. Acute cognitive dysfunction can affect your judgment, attention, and even calculations. Therefore, it is said there's a deadly circle of poor diabetes control, depression, and cognitive dysfunction. I have brought this deadly circle for you. Patient adherence to care, hyperglycemia increases, the adherence comes down, frequency of severe hypoglycemia increases, patient error increases, giving rise to accidents plus complications, giving rise to more depression. There can be mortality and morbidity, and the cognitive dysfunction can contribute to mortality and morbidity. It's a beautiful scale circle to say the impact of depression, cognitive dysfunction, mood disorders on the diabetes control and also diabetes outcome. Fear of hypoglycemia is one aspect of the mental disorder. So also there are many perceived barriers for the psychological condition. To address it, the mental health barriers to address it, there are a few things. At the patient level, there is stigma to consider mental health as somebody is having it, denial and depression, lack of knowledge about depressive symptoms. At the practice level, many of us, including me, we have lack of access to mental health specialists, lack of access to diabetic distress, depression, lack of a reminder system. Now, how can we alter it? Educate patients about diabetes, and don't say directly, but there are many ways of talking to them about the pushing away depression and distress. I'll give a small example. A non-diabetic, well-controlled diabetic is better than a non-diabetic. The great sentence helps them. To saying that having diabetes is a blessing, to say them that full life despite diabetes is possible today. Diabetes reversal or diabetes remission, quote unquote, is possible today. So these are the strategies to address this. Explore opportunities to assess patients' mental health and concerns in clinical visits. And there are a few things like inadequate mental training that can be done. I think the Vaishali is planning it. It was launched just now. Workload demands, time constraints, managing the physical conditions, and I have given at provider level what can be done. There are many treatment options. I will not go to it. All of you know it. We have CBT, cognitive behavioral therapy. The other ways of psychotherapy is an antidepressant medication. The question was asked in the previous session. I will end by saying, what are the recommendations? We have few recommendations in our country, but I like the recommendation. The globe is one, like Shashank said just now. I've taken the diabetes corner recommendations because I liked it. But dear friends, I must also say my apologies to the Indian task force, which is on the verge of developing some guideline. Number one, individuals with diabetes should be regularly screened for diabetes-related psychological distress, like diabetes stress, psychological insulin resistance, fear of hypoglycemia, and also sometimes a psychiatric disorder like depression and anxiety. By a validated self-report questionnaire or clinical interview, that has to be Indianized. That has to be customized to our country. Plans for self-harm should be also inquired into. Following groups of people with diabetes should be referred to specialized mental health care professionals like significant distress with diabetes management, persistent fear of hypoglycemia, psychological insulin resistance, and having a psychiatric disorder, of course, have to refer to the group. Number two, collaborative care by a combined team should be provided for individuals with diabetes and depression to improve depressive symptoms, to provide adherence to antidepressant and non-insulin anti-hyperglycemic medications, and also for the glycemic control. Last one, Psychosocial interventions should be integrated into diabetes care plans. I think if this is done, if this is, again, I'll quote my younger brother, my very dear friend Sanjay Kalra. He, in 2017, when the ADA gave its outline of the standard of treatment, he rose up and said that the customization also must be done on the psychosocial aspects. Lo and behold, from 2017, ADA has accepted Sanjay Kalra's comments, and in every issue, every year, there's a full 5-page, 6-page chapter. How do we manage this mind-body medicine, the psychosocial aspect of diabetes every year? So therefore, psychosocial interventions should be integrated into diabetes care plans like motivational intervention, stress management, coping skills, family therapy, and case management. I will not go details of it because that is the details of the treatment. I will not dilate it here. I will not dilate also the treatment to the children and adolescent. I'll leave this document here. I'll conclude by saying that experience of living with diabetes is often associated, more often than not, with concerns specific to illness. And this concern can cause in the patient, not the patient, in the person with diabetes mellitus, some distress. We were given a name to it, diabetes distress. If one word goes today from this meeting, that we must have euglycemic happiness. If the blood glucose are controlled, we have said the 5th sign of the health next to pulse, BP, temperature, respiration is blood glucose estimation. If the blood glucose are normal, there is euglycemic happiness, euthymia. That will take away diabetes stress, take away the insulin resistance psychological, and the fear of hypoglycemia. Now, wide range of psychiatric disorders, starting with depression and anxiety and mood disorders, are more prevalent with type 2 diabetic patients, also type 1 diabetic patients, compared to general population. People living with diabetes and depressive disorder, they are at increased risk for all-cause mortality compared to people living with diabetes but without depression. Please remember this. Those who have depression and the anxiety disorders are prone to increased all-cause mortality. Like Nachiketa asked the Yama, we all want to be immortal. We want to live long enough. So what costs short the life is to do away with the depression. I like the way Jomani asked the first question. He asked the question, Nitin Kapoor, in the first session. He said, is sexual dysfunction a driver for obesity treatment? We live for 3 things: power, wealth, and sex. Now, like that, if this concept goes to the diabetic individuals in a different manner, that if you have euglycemia, you're well controlled, well monitored, well cared for, cooperate, a good partner in the care, you will live long enough. And it has been shown by my friend Mohan every year, people who live beyond 100 years with diabetes, type 1 and type 2. So dear friends, I'm very passionate to say that this concept must go, that if you want to live long enough despite diabetes, full life despite diabetes, centurion and beyond, one must see that we do not have this, and there are ways to dispel it today. All individuals with diabetes must be regularly screened in the Indian manner for the presence of distress, diabetes stress, and symptoms of common psychiatric disorder. And diabetics with mental health concerns, they witness that if you take care of it, there's improving the quality of life, increase in the functional activities, the risk of complication comes down, and the healthcare cost, as I showed you, comes down. Therefore, dear friends, by addressing the MBM in diabetes mellitus, one can improve self-care, quality of life can be improved, function can be improved, and the cost can be cut short. And primary care should incorporate, is one of my friend Kamlesh Kunti, all of you know him. He has written recently that the primary care should have little bit in its own way. How do you give behavioral therapy? How do you give a patient-centered approach for a motivational interviewing? And there are videos available which I can pass on to you. And how do you manage the stress in a diabetic? And how do you give them, there's a diabetes coping skill. So how do you give them the skill for coping with anything, depression to anxiety to disorder to mood disorders, and how do you provide family therapy and collaborative case management? Dear friends, thank you very much for a very patient hearing. I'm delighted to be here, and my apologies, even though I'm one of the advisors, I could not be present physically because tomorrow is a very spiritual function, and I know that's the in the Sri Aurobindo Ashram, the Ashram Foundation Day, where I'm a member to speak few words. Thank you very much. My sincere regards and greetings to you.
Thank you very much, Professor Dr. A.K. Das, for covering the mind health management, all aspects of mind health in a short duration. I think because of lack of time, we may not be able to take questions right away. The next session, whether we get some time to take a few questions. At the same time, before moving on to the next session, we would like to take this opportunity to congratulate Dr. Vaishalideshmukh. She has come up with a very good initiative. This is like what we can say. This may have been a secondary topic, but mind body medicine, she has taken it to the forefront, and this is very important. And as we know, we are experiencing so many speakers speaking on this particular important topic. Thank you very much, madam. And this is a very good initiative. And we would like you to continue every year in the same way. Moving on to the next session of Professor Dr. Manoj Chadha. He is going to speak to us on economic health for mental peace from diabetic depression and distress. He is going to speak to us on economic health. Dr. Manoj Chadha is consultant endocrinologist at PD Hinduja Hospital and Research Center in Mumbai. He is a past president of Maharashtra Endocrine Society, Mumbai, and he has experience of working in University of Ulm, Germany, in the Department of Endocrinology under Professor E.F. Pieper, and also he has experience of working in Saudi Arabia from 1988 to 1990. Over to you, Dr. Chadha, for economic health for mental peace.
Thank you very much for this opportunity. And it's going to be a big change from whatever you've been hearing since morning, and you will hear later on in the day also. Yeah. So what I'm going to do in the next 15-20 minutes is just give you a brief overview of how I have seen my life in the last 35-40 years. And I'm pretty passionate about the whole thing because it's been a learning lesson. And I do talk to my juniors at how being at peace as far as the finance part is can help you settle in life and take better care of your patients. So this is more directed towards the medical fraternity than the patient fraternity, what we've been discussing up till now. And talking from my personal experience, I finished my MD, I went into the DM program, and I did find my right partner to get settled down with. But then this question that comes up for a lot of people is, do we continue with an academic career or do we go into consulting practice? Its pros and cons. What are the issues that are in setting up a clinic? When you're young, you're also struggling with your work-family balance. And eventually, when you do reach a certain stage where you can enjoy the fruits of labor, it's very important to enjoy those fruits and not just keep on struggling from as if it was day one. So this is what I have learned, and I'd like to convey to the whole audience. See, the whole struggle in life, is getting enough roti. And today it's more of a focus on the bland food than the rich food. We would like to have our own makan and some the kapda part you can see. For those who can make out, is these people are really stretching their clothes, but we don't need to have so much of stuff going on. And occasional holidays with family and friends. These are the basic essentials of life. And if you can get this and a peaceful night's sleep, then you know that you're mentally happy. What I'm going to discuss in the next slide is basically under these headings. What is income? How should we be investing our money? Doctors do make a good amount of income, but they really don't know where to put their money. You have to keep in mind certain other things that go along with income, that is taxation. The insurance part is very important for our mental peace. Making a will while we are still in good health, and then we'll try to summarize how we go ahead with this. I want to stress that I'm not a financial consultant. It's just that I'm an experienced doctor, so I can take this liberty of talking to you people. Now, there are some things that we should understand. What is rich and what is wealthy? Now, when we say rich, it means that you should be able to afford most of the things that you need. most of the things because it may not be possible to take care of everything. But the wealthy part is people who can still do all this without working hard for it. We are rich, but we work for 12 to 14 hours a day. We can't afford to sit at home and not work. So that's the difference between being rich and wealthy. To become wealthy for us, we have to have an alternate source of income. And that's something which is very important. So unless you have inherited from your parents or from your relatives, you have to continue to slog to convert your direct income into alternate income. The other thing which we learned from COVID is that there are certain obligatory expenses which we call as life expenses. And then there are certain optional expenses, lifestyle expenses. Eating food, paying your electricity bill, going to school, paying for your child's education are obligatory expenses. Going on a holiday, a 5-star meal, buying a new vehicle are optional expenses. You need to understand the difference between two. We have always thought that income, expenses, and what is left will be savings. What has to change is income, first the investments, and then what is left is your expenses. And in a very famous book, Rich Dad, Poor Dad, it has been said that once you have done your investments, then you will work hard to take care of your expenses. Important to define the goals of your life right at the beginning. See, if someone is 60, 65 like me, doesn't have to think of this. But if there are 30, 40-year-old doctors in the audience, it's still time to plan for your self-education or your children's education, the marriage of your children, care of parents, leisure time, vacation time, and how to take care of retirement. So all this has to be in separate goals, in separate buckets, as they would say, and how to go about defining the needs for these goals in life would be depending on your risk appetite. So the important thing, as I mentioned, is you need to divide this into what you need immediately within a year or two, what is short term, that means between 3 to 5 years, and what is after 5 years is long-term goals. So you could see education, marriage, vacation time, retirement. These are all different time-bound goals. And you must invest right at the beginning of the month and not at the end of the month, as most of us do. And you should invest more as your income increases. There is not a fixed amount that has to go in. And the long-term goal investment should not change. They should go on as it is. Market factors should not sway your investment plans. The various options that are there available to us, which are pretty known, is the PPF, the Public Provident Fund. You have the stock market, which has become very popular in the last 2-3 years. For those who are not aware, mutual funds, fixed deposits. Real estate is something which was very popular 30-40 years ago, but seems to be losing its sheen for various reasons. And gold, all said and done, is still a good source of investment for most Indians. How much money does one really need? A couple of years, I remember I met one of my patients and he said, it's very nice to earn. It's very nice to have a healthy bank balance. But if you don't spend that money, then you're a fool, because the earning is at the expense of time, which you could have used for something else. So just working and earning and saving and not using it at the right time is something criminal. So you should be able to build a corpus which keeps you comfortable as you grow old. And there are various formulas, but what you can work on is getting a 30x, 25 to 30x of what your annual income or annual requirement is today. So not income, but what your requirement. So that 25, 30 years down the line, you can live on your corpus. The other way is to look at what is called as the 4% withdrawal rule. Corpus X, 4% of that X should be able to give you enough to keep you going month after month after month. And that will give you some idea. For example, I was doing some calculations yesterday night. If you're looking at, say, between 1 to 2 lakhs per month today, then you need, that's 24 lakhs a year into 25, that gives you about a 6 crore corpus. And if you work the other way around, 6 crore corpus, 4% of that is 24 lakhs a year, it'll give you 2 lakhs a month. So this rough calculation, each one has to do depending upon their hunger, their appetite, their needs, and their desires. This also takes care, into the inflation problem, because whatever you are talking today with a 6 to 8% inflation, it'll double in the next 10, 12 years. So that is something that you need to keep working on. And one of the best things that I learned about 4 years ago when I started preparing for my presidential oration is difference between regular income, which you get advice from a agent and he helps you filling out the form, and the direct investment in which you can take advice from an agent or a planner, but go on the websites, which are plenty of them, they allow you to doing direct investments. Remember that when you take advice in filling out forms by agents, you pay them 1% of the corpus every year till that fund is going on. It's a huge amount of money. And in 25 years, it may turn out to be 30 to 40 lakh rupees. So please do your homework, talk to an agent, talk to an advisor, but do your direct investments. Another very interesting thing that they say, the eighth wonder of the world is the power of compounding. Let's look at this example. There is an endocrinologist aged 35 years. He invests about 2.5 lakhs annually. So that's about 20,000 a month from the age of 35 to 60 over 25 years. And there's someone else who, decided that, no, okay, 10 years, let me enjoy my earning and then I'll start investing. So instead of 35, he started 10 years later on. And instead of 25 years, he invested for 15 years, but he invested 5 lakhs a year. That means double the amount. So at the end of their 60 years, who do you think would have a higher corpus? Someone with 15 years, 5 lakhs at 8% is going to have about 75 lakhs in his corpus, has invested 75 lakhs, whereas someone who has been going slowly for 25 years has invested 62 lakhs 50,000. This is just an example. His corpus at the end of when he's 60 years is about 1.5 crores, whereas on the other hand, this younger doctor who invested earlier has got about 2 crores when he's actually invested less. This same thing, if the rate of return was higher, this gap would go on increasing. I use the word inflation. So keep in mind that with inflation, your expenses will go up and the value of your corpus will go down. So that is why be a little liberal now while deciding on the corpus that you want to get to, instead of, living longer, 75, 80, 85, and then finding that your corpus has started dwindling down. So that's why this inflation has to be kept in mind. We all are, susceptible to the what is going around us. So it's important to have insurance, health insurance, very, very important. Good old days, we were taught doctors don't charge doctors get free treatment. Not true anymore. And medical treatment, surgical treatment can be very expensive. I think there are enough examples around us during this COVID period, what happened. So health insurance, maximum possible, should be tried for, but it should be always more than 10 lakh rupees for the family. And then you can go up for another 20, 30 lakhs as a top-up thing. Life insurance is necessary when you have dependent members. So that means in the growing part of your life, once you are 55, 60, you have taken care of your responsibilities, you have a decent corpus, maybe you don't need a life insurance at that time. Your premises and car obviously also need an insurance. The important take-home point is not to confuse insurance with investment. You keep getting so many offers, options. Please ignore them. Don't look at them. Term insurance for the cover of life is what you need to take, and not these other insurances. Take adequate amount of insurance, but take multiple covers. So if you want a 2 crore or a 3 crore, then don't take one policy, take 3, 4, 5 policies. Because as you grow older, your requirement for insurance goes down. You can stop, some of these covers. Just stop the investment, paying the premium. The insurance will lapse, but you don't lose anything. Because remember, in term insurance, if you live through that period, you don't get anything. What you don't need is endowment plans, but because that only benefits the agent and the insurance company. We have to live in this world with taxation. There are no free meals. So if you are earning, you have to pay income tax. Please pay it properly, liberally, because today cash income is of no value. It's better to have income which is shown and taxed. As doctors, our income from patient care, from consultation is tax free. It's free from GST. But if you are taking lectures, you're giving honorary advice, advisories, or income from any other sources, especially from the rental income of commercial spaces, you have to register for GST, and please clear GST on time. Otherwise, you can get into serious trouble 3 to 5 years down the line. And it's also important to know when you're calculating your taxation part that capital gains, long-term and short-term, are there with us. And it's okay. You don't have to crave about it, because if you have more income, more investments, then be happy about it. So as I mentioned, our goal eventually is to retire peacefully. I mean, you see the IT workers, they want to retire at 40, 45. Doctors, even if they plan at 65 or 70 would be reasonable. You have a longer time to save, but please plan for retirement. I've talked about how the corpus should be made. Get a financial advisor to tell you how to reach that corpus. And you must keep this 4 to 6%. So safer is 4% withdrawal, so that your corpus will never get over. You can use your paper and pencil and do your calculations. But I think this is important, that the good old saying, invest in your children, they are your old age support. I don't think that should be carried home. Please look and plan for yourself. There are different types of mutual funds and equity. I'm not going to go into the details, but the important thing is that as you grow older, after 60, you start transferring from risky investments to less risky, less return, but safer investment options like debt or hybrid funds or fixed deposits. But be happy with the safety of your investment, and that's important. One of the things that we don't like to discuss anytime is death. But death is an eventuality for all of us. And unless you consider yourself immortal, Dr. Das was talking about immortality, you have to make a will and be prepared for eventuality. Otherwise, your hard-earned money will get stuck up. Your children, your spouse, your other family members who should have access to that money will not be able to have. And that holds especially true if you've got the immobile properties, which can be a big problem for those who are left behind. So please make a will at the earliest, and those who don't have a will should make it tonight or tomorrow morning, because it's one of the easiest things to do. So friends, I have given you a sort of roadmap which youngsters, and as a matter of fact, all of us should do. I have gone through it personally, so I can talk with some confidence. I am not a financial person, but everyone should understand some of these things, because it's like some patients let their doctors take us for a ride, and they read up here and there. So similarly, doctors should also read up a little about finance, understand what they need, and so that they can't be taken for a ride. The important thing is to understand what we need and what we want, because wants can be endless and can be a source of a lot of heartburn. If you can define your needs, you're going to have a happy, I won't say old, but middle age. And don't evade taxes. It's better to pay taxes and have a healthy balance sheet, because from experience, I'll tell you, when you are starting your business and if you don't have funds with you, you need loans, then it is your healthy balance. It is your capital which helps you get loan, which will help you grow and will lead a nice and fruitful middle age. And as you say, if you want to be, peaceful, you need to have a good financial plan in place, and later on a good corpus in place. And the health issues are always going to be there. But if you are at mental peace, health issues can also be taken care of. I know we're not going to have time to discuss, but I'll be happy to take questions on this email ID, or if Vaishali can put you in touch with me, so some other mean. And I hope you enjoyed my talk as much as I enjoyed taking it. Thank you very much for this hearing.
Thank you, sir. Thank you very much for very enlightening lecture. And stay changing the perspective of economical health for the mental peace. It is really well appreciated. And stating the difference between the rich and wealthy and obligatory expenses versus the optional expenses, which was really the eye opener for all of us. Now the floor is open for the question answer.
Thank you, Dr. Chadda. I had the fortune of attending your ACCON presidential oration in Bhubaneswar, and my family is grateful to you because I don't know how many of us here are financially educated and updated. Thank you. Thanks a lot for your wonderful talk.
Yeah, I think the first time I did this was in 2018 in the presidential oration, and I did another talk in 20, and now after 2 years in 22. Probably it's a learning experience for me also.
So good afternoon, sir. Dr. Kiran from Abbott Healthcare. First of all, thank you so much for this wonderful lecture. First time I could hear a senior consultant speaking about finance, and it is very important. So two questions from my side. You took the name of Rich Dad Poor Dad, which I have read. Are there any more suggestions of books from your end to be more equipped about finance? That is one thing. Second thing, if I want to open up a clinic, what are the things which I need to take care so that I be in a good books of government in terms of taxes and other things? If you could highlight on that, it will help.
Kiran, I don't think I'm competent to tell you in this period how to start a clinic. That's a separate, I think we should ask Vaishali to next time give a workshop in her conference so that we can spend 3-4 hours and discuss this. Oh, there are multiple books, but this book is something which I have read half a dozen times, and every time Rich Dad Poor Dad teaches you something new. So probably keep it, invest, it's hardly 150 rupees. Keep it with you and read it every year at least. It'll keep you going.
I'm sure you can see the jam-packed hall. So people don't want to go for lunch. They want to be and listen to this important topic because hardly doctors are used to economic health talk. I think health in terms of economics is so important. That's what I've learned from Dr. Chadda sir. And that's why I'm so glad that he took up the talk today. Any other questions? Yes. Yes,
I just ask is that whether this financial piece that you are talking about has reflected in the patient care.
Yeah, whether she wants to ask whether the financial piece is going to reflect in the patient management. Am I right, ma'am?
Patient care.
Patient care. Yeah.
No, please. Your fees has to be decided by you depending upon your area of practice, your city of practice, the patient's affordability. But please don't underprice yourself. See that you are having a decent amount of fees for the sort of effort that you put in to reach this level. Definitely, if someone cannot afford, you can give them a concession, but don't undersell yourself. It's very important. And I repeat, if you are financially healthy and well settled in life, you would be doing much better work for your patients.
Yeah. Thank you so much. Thank you so much. This session has been concluded.